So good morning, everyone. At the outset, I would like to thank Rohan for including me in this instruction course. So I'll be talking about follow-up and addressing complications from laser treatment. So let us see a case of central serous retinopathy. Now, if you see this patient, he had macular fluid in the color fundus picture that you can see. You can see a typical dome-shaped subretinal fluid in the OCT. The FFA showed a leak just nasal to the fovea. Now, this patient underwent a focal laser. The subretinal fluid resolved, and the patient was all fine. 2 months down the line, the patient came with a recurrence of subretinal fluid. Now, we might actually think it might be a recurrence of CSR, but on clinical examination, the patient had a scar just nasal to the fovea where the laser was done. And when an FFA was done, it was features of CNVM. The patient underwent intraretinal anti-VEGF and the fluid fluid resolved and the patient was all well. Now, what this happened? When we do a focal laser, we have to remember that we are not trying to burn the RP there. We are just our purpose of doing the laser is just to stimulate that RP. So ideally, when we do a laser for CSR, try starting with the test burns outside the arcade, come to the faintest burn, and then probably even you might reduce it a little bit and then hit the leak. So you should not burn that area. So if you have a choroidal neovascularization, get an FFA ICG or OCT angiography, and the treatment for that will be anti-VEGF injections. So also along with that, sometimes what can happen is there is a macular fluid, right? And most of the time the leak would be just beneath the in the fluid. So when we hit the, there's a tendency when we hit the leak, you don't see any burns. And what happens is the natural tendency is to increase the keeping on increasing the power. And when we keep on increasing the power, the next thing what happens is there will be the laser scar would be it will be much more disastrous, powerful burn, and then you end up having atrophy. That is all creeping burns. And what happens is over a period of time, if you see, when you do a fresh laser, it appears white, and over a period of time, the pigmentations happen later. And that is when this laser scar actually enlarges and it can actually cause a scotoma since it is very close to the fovea. So how do you avoid that? One, like I said, use the lowest power. At least try to do laser, focal laser only when it is more than 500 microns away from the fovea. If it is subfoveal, yes, the best treatment I would recommend is photodynamic therapy, but sadly we don't have that anymore. So subthreshold laser treatment is a better option. Now, when we talk about pan-retinal photocoagulation, this I feel is the most important complication that we all tend to ignore. The patient, this is one of the most common reason why the patients tend to drop out. And we see a lot of patients, they would have undergone one sitting of PRP or two sittings of PRP, lost to follow-up, and then they come to us with the vitreous hemorrhage or the TRD. This because we do not address this complication as much because we just take it like, laser is there, some amount of pain will be there. Do not disregard that. It is one of the most important things that we should all look into. So if the patient has pain, give them cold compresses. You can give them oral non-steroidal anti-inflammatory drugs. And when you do the laser, do it with a reduced power. You don't need to burn that end thing. It's not like that retina is, yes, it is hypoxic. You want to turn it to anoxic, but you don't want to create a hole there, right? And the another thing I would recommend is doing multiple sittings. See, we all talk about PRP in 2 to 3 sittings, but no, all 5 fingers are not alike. If you see a patient, the pain threshold for every person in this room is different. So when you do a laser for such patients, there might be some patients who might not tolerate the discomfort or pain that much. There's no hard and fast rule that you have to finish off the PRP in 2 sittings. If the patient wants, give them 4 sittings or 5 sittings. The purpose is to do a good laser, not the number of lasers. So even if the patient tolerates 200 burns, yes, fine, go ahead with 200 burns and take it to multiple sittings, but make sure that the patient completes the PRP. The another thing is, sometimes what happens is choroidal detachment. Now, if you see the image on the left, you will see a large proliferation in the disc, around the disc and around the arcade. This patient started underwent PRP, and after the PRP, the patient had a huge choroidal detachment nasal to the in the nasal periphery, and this is in the right eye, even can see a small choroidal detachment there. Now, when you see a patient with choroidal detachment, how do you go further? Withhold further laser. The patient might be coming from 100 kilometers, 200 kilometers. Just because of the patient comfort, do not add laser because inflammation is always there. Whenever you see choroidal detachment, there are two causes. One is hypotony, another thing is inflammation. By doing a laser, you're only going to further worsen it. So to withhold further laser, start the patient on a hourly topical steroids, start the patient on cycloplegics. A short course of oral steroid actually helps. If the blood sugars are under decent control, you can probably give a short course of oral steroids for probably 5 days or 1 week, and it usually comes down in a week's time. Also, at the same time, try to look for systemic hypertension. This is one thing which I have seen in my practice. I have very few patients who have a developed choroidal detachment, even post-surgical. Like, we do small PRP here and there after the surgery, during the surgery in a TRD case. And when I look at these patients, usually will tend to have a systemic hypertension, and most commonly they will have a renal parameters will be deranged. They might have been a diabetic for. I just had a patient 1.5 months back, type 1 diabetic, 45-year-old guy, did the surgery. He was on OHA, had asked renal issues, no renal issues. Creatinine was 1.2, but when I checked his urine sugars, his microalbumin was around 1400. His urine protein was 4 plus. So nephropathy has already started kicking in. And what happens is sometimes the physicians don't address the nephro problem. They just look at the blood sugars and they keep on treating that. So when you see choroidal detachment, make it a point that you look at the hypertension systemic parameters and also the renal parameters. Now, when you do the laser, when you see a proliferative diabetic retinopathy and you see proliferations, we want to add the laser, yes, but try to steer off away from the proliferation. Now, this is one of my patients. My junior had done the laser. If you see here closely in the superior part, it is a freshly, this is 1 week post laser. You can see the superior burns. I don't have a wide angle picture, but you would have clearly seen the lasers come from above, and you can see the nasal polyps here, and all the polyps came here very close to the proliferation, and right in the center, in the polyp, a laser burn hit, and you can see it just opening up. This patient, post 1 sitting of PRP, 2 weeks down the line, patient developed a combined retinal detachment and had to be operated. So whenever you see proliferation, stay away from the polyps, at least 2 to 3 disc diameters away. And grid lasers and focal lasers, yes, like I said, when we do a laser, remember, especially in the macular region, the RP is the thinnest at the fovea. And as it goes to, you go to the periphery, the RP becomes thicker. So when we do the laser in the macular region, the power should always be less. So what happens is that is the reason in grid lasers, which we rarely do nowadays, we prefer to do more of focal laser or anti-VEGF. But when you do a laser, try to keep the power burn less, because if you do a larger power, you end up creating a breach in the RP Brooks membrane and you're inviting trouble with the CNVM. So if you have a CNVM, you have to treat it with anti-VEGF injections. Sometimes because of heavy burns, you might also develop subretinal fibrosis. And because it is a macular region, such a sensitive area, these patients are definitely going to have some vision field loss or scotomas. Now, barrage laser. You see a break, HST or something like, or a lattice degeneration with hole, you tend to burn them with the lasers. And when you do the laser, you don't need to have chalky white burns. That is not the sure factor that the patient will not develop an RD. Yes, if you see them, just a decent enough burns should be enough. Complete the entire region. Make sure that it is either you encircle the complete lesion or you connect it to the aura. So what happens is, when you do a laser, there is some amount of inflammation that is happening. Most of these patients tend to have a PVD. So what happens is all these inflammatory cells come and settle over the macula. And what happens is, next is a epiretinal membrane. When you have an ERM, you can actually, if the patient's vision is fine and the patient is not symptomatic, you can observe. If the patient is symptomatic, metamorphopsia, the patient has to undergo a surgical removal. Now, another thing is anomalous PVD. Now, like I think Dr. Shishir already mentioned, many times when a patient comes to you with you examine the patient, you see lattices. Now comes the question next, what do you do next? If the patient there are certain indications when you do the laser. One, if the patient is undergoing any eye surgery. Suppose a patient with lattice is undergoing a cataract surgery. Now, if you remember, we see the patients of post-cataract surgery day 1 week or 1 month. Now, do you know what is the follow-up like that? Because after 1 month or even after PRP or everything, 1.5 month, that is the time. What happens is some amount of even though you don't have a PCR, some amount of hyalur disturbance is happening, and because of the inflammation, the PVD is going to get evolved, right? So when you see a cataract surgery patient with a or any LASIK patient with a peripheral retinal conditions, you have to treat it. Like LASIK, if when you do the LASIK, Shishi just told, when we keep the suction, there is a theoretical chance that the PVD might get evolved. Especially if you look at PRKs and all, we don't do any suction. So that, if you ask me, there's no need for a peripheral lasers, but are prophylactic lasers in such condition. But then, medical legal aspect. If you all know, we all say the LASIK patients are the most story patients. Because the reason, because you have a 6'6" patient and you want to hit them give them 6'5", 6'4", right? So such patients is always better to be safe than sorry. You see a peripheral lesion, you do a barrage and keep it. So if you have a patient with undergoing, if you're undergoing a research, so then only do a laser when it's indicated. Otherwise, keep a close watch. Thank you.
Thank you. Does anybody have any questions? Thank you. We'll move on to the next section. Thank you.